Hi guys, this is our final action research project presentation. This is Natalie and part of the group members are Kelly and Aaron. So, speech-language pathology for patients in palliative and hospice care. The general problem were that speech pathologists really are not viewed as an integral part of the palliative care team of professionals. So, our specific focus of the study was how do SLPs best facilitate management of patients diagnosed with dysphagia who are in palliative care, and to examine the extent to which this therapy improves patient safety and overall quality of life. Our question, how do SLPs facilitate management of swallowing disorders in palliative care to maintain and improve safety and quality of life? Overview of outcomes/participants. Outcomes, we wanted two main outcomes. One was quality of life, measures the patient swallowing and how it relates to their quality of life, and this was done using the DHI, which is the Dysphagia Handicap Index. And number two, compliance, presented the patient's recommendations and post-treatment and measured compliance to treatment techniques. Participants, we chose 10 participants over the age of 65 with dysphagia who live in a long-term care facility. Chosen based on their entry to palliative care, so they have to have been diagnosed with less than 6 months to live. Individuals who were heavily sedated or not cognitively intact were not chosen for this study, so they had to be cognitively aware and alert, and individuals presented with symptoms of oropharyngeal dysphagia were needed for this study. Prior to initiating cycles, procedure for outcome number 1, we gave the participants a consent form and the participant information sheet. We performed the initial evaluation of the 10 participants. We administered the Dysphagia Handicap Index to all 10 participants. So this is an overview of the DHI. Figure 1, there are examples of statements of the 3 areas the DHI covers: physical, functional, and emotional. The participant rates the impact their swallowing has on these 3 areas from 1 to 7. 1 being normal, 7 being the most severe. The letters next to each statement indicate which of the 3 areas the statement targets. So for example, 1F, I avoid some foods because of my swallowing problem, so that's a functional statement to see the impact their dysphagia has on their functionality. And then this one, 1E, is an emotional. So the impact it has on the participant emotionally. I am embarrassed to eat in public. And lastly, we have 6P. I have to swallow again before the food will go down. This is actually a physical, a statement to target, like to see the handicap rating in the physical. The test is scored by totaling all the ratings and totaling all the areas for each subtotal. For example, the total score of 60 and a physical 20, a functional score of 20, and an emotional score of 20, you would compare it to this scale, and the score would indicate the severe impact, the impact on the individual's dysphagia on their overall quality of life. And for this one, it's severe, because right here is the mean, and our total score is 60, so that's right around the mean, so their handicap would be around 60, or would be considered severe. So prior to initiating the cycles, we administered the DHI and this was the baseline of the DHI. Figures 3 shows the baseline of self-perceived handicap rating for each of the 10 patients. The colors are representative of the grand total in each subtotal area. So for example, the blue is the total, the grand total. Red is the total for the physical questions. The yellow is the total for the functional statements, and the green is the total for the emotional statements. So the scores in figure 4 were compared to the table and rated from mild to severe. So patient 8, you could tell it's a little more mild. We had 3 patients who were extremely severe, which were patients 1, 2, and patient 7. Some are more on the average severe, and some more moderate. So then figure 4 shows a breakdown of the participants in terms of their self-perceived severity rating. So 60% of the participants in the study perceived their dysphagia rating as severe, 30% as moderate, and 10% as mild. Cycle 1. Cycle 1, so the procedures for outcome number 2, the FEAST was conducted as an initial evaluation of the patient's swallowing function. The SLPs gave recommendations of appropriate techniques and diet modifications for the individual patient based on the results from the FEAST. The SLP conducted interviews on the patient and their caregiver on which swallowing techniques and food consistencies work best and worst for them in improving their quality of life. The SLPs made observations by keeping journals on the patients to see what therapy method worked the best for each individual patient. The measurements for outcome number 2, just as a reminder, was the compliance. 10 patients received diet modifications to thickened fluids and food-based on their FEAST results. 1 out of 10 patients categorized as mild received a 2 on the PAS scale and was recommended on a regular diet. 3 out of 10 patients were categorized as moderate, received a 4 out of 5 on the PAS scale, and they were recommended on a pureed diet and thickened fluids. And 6 out of the 10 patients categorized as severe in their disorder received a 7 and 8 on the PAS scale, were recommended to be NPO. So this is the measurements for outcome number 2 in a graph. So we're comparing here the patient's DHI baseline results to their PAS results. So their FEAST results converted to the PAS scale. So those that self-identified as more severe quality of life impact were actually severe on the PAS scale. Cycle 1, measurements for outcome number 2 continued. Patients received different recommendations for swallowing techniques and maneuvers. Effortful swallow, Mendelssohn maneuver, head rotation, head tilt, chin down, and chin up postures. The interviews were conducted for their patients and their caregivers. Questions that were asked include, how does it feel when you swallow? Are you comfortable eating and chewing in certain foods? Do you tend to cough while eating or drinking? Would you prefer softer foods? And is having a tube better for you or your loved ones instead of directly feeding them? And the responses were charted on the left, and also we made a visualization for the patient's responses to the interview questions. The word cloud represents the responses by the patients, and the most frequent word used that is hard, chew, and cough. Other words were permanent, hurts, softer, tried. Cycle 1, observations made by the SLP. The patient who was categorized as having mild swallowing disorders benefited from having a regular diet, but did not benefit from the maneuver due to their lack of strength holding their breath and lifting their head. The patients who were categorized as having moderate swallowing disorder benefited from pureed diets and thickened fluids, but did not benefit from the maneuver, which also was due to their lack of strength in holding their breath and lifting their head. They seemed uncomfortable throughout the therapy session. The patients who were categorized as having severe swallowing disorders benefited from an NPO and had tubes inserted. Swallowing maneuvers were not attempted on these specific patients. Cycle 1, the DHI result post-treatment. So we re-administered the DHI after the cycle 1 treatment, and the total and some of the sub-area scores decreased in this cycle, indicating that there was a decrease in the handicap perception and a slight increase in quality of life. The percent of participants' severity rating stayed the same as baseline, so we still had 60% severe, 30% of the participants were moderate, and 10% of the participants 10% of the participants were mild. Cycle 2. Cycle 2. Procedure for outcome number 2. The SLPs gave recommendations of appropriate swallowing techniques and diet modifications for the individual patient based on the results from the interview and observations. Treatment sessions were held once a week. The SLPs recommended oral motor exercises instead of swallowing techniques because The patients were unable to use their strength to follow techniques, which in turn did not improve their quality of life. The SLPs conducted interviews on the patient and their caregivers on which food consistencies and oral motor exercise work best for them in improving their quality of life of swallowing. The SLPs made observations by keeping a journal of the patients to see what therapy method worked the best for the individual patients. Measurements for outcome 2. Oral motor exercises conducted included the Masako maneuver. This is done by the patient holding their tongue forward beneath the teeth while swallowing saliva. This exercise is done to improve movement and strength of the postereo-pharyngeal wall during swallow. The diet consistencies of the patient have not changed since all the patients have benefited from their new diets. Interviews were conducted after presenting the new exercises. Interview questions included: how does it feel when you swallow? Are you comfortable eating and chewing certain foods? Do you tend to cough while eating or drinking? Are you comfortable with the new exercises for swallowing? And their answers are on the right, and it has improved since the first interview. This word cloud represents the words that were used most in the interviews, and those words were better and now, which represented that the new results were better now in the new therapy exercises and diets. You also see softer, cough less, and easier. Observations by the SLP. The patients complained their diet plan with their diet plans and have not given The patients were compliant with their diet plans and have not given any complaints except for the taste of the food for the patient who is receiving the period diets. Since all the patients were cognitively intact, they were able to follow directions for the Masako maneuver exercise. At the end of cycle 2, we re-administered the DHI, and these are the results for post-treatment of cycle 2. In this cycle, participant 4 had a change in the handicapping severity level. He changed from severe to moderate. And overall, the blue total numbers decreased as well, indicating that there was an increase of quality of life for these participants. The analysis of the participants' handicap severity rating. So 50% of the participants were now self-perceived as severe, 40% were moderate, and still 10% were mild. Cycle 3. Procedure outcome for number 2. The SLP gave recommendations of the appropriate oral motor exercises for the individual patients based on their results from the interview and observations. The SLP conducted interviews on the patients and their caregivers on which food consistencies and oral motor exercise work best and works for them in improving their quality of life of swallowing. The SLP made observations by keeping a journal of the patients to see what therapy method worked best for the individual patients. Lastly, the SLP increased the number of sessions in a week. The interviews were conducted again for cycle 3. The interview questions included: how does it feel when you swallow? Are you comfortable eating and chewing certain foods? Again, do you tend to cough while eating? Are you comfortable with the new exercise for swallowing? And do you think you have benefited from having more therapy sessions in a week? And that one was the most conclusive, that I feel the therapy is helpful, so I would like to have more sessions in a week. They really enjoyed more sessions in a week. So this is the word cloud that represents the words that were used most in the cycle 3 interview, and those words were feel, helpful, and learned, which represents the participants were self-monitoring and feeling that the therapy is helping. The participants are learning more from the sessions, and a few requested even more sessions a week. The patients continued to show These were the observations made by the speech pathologist. The patients continue to show compliance with the modified diet and oral motor exercise. No complaints have been made except for the taste of a pureed food. Patients seem content with the new changes. More therapy sessions a week benefited the patient to achieve better quality of life. Patients seem to agree with having more sessions a week when they were asked about it during the interview. Treatment sessions were increased to twice a week. So these were the DHI results post-treatment for cycle 3. In this cycle, participants 5, 9, and 10 have changed their handicap severity rating. 5 and 9 went from severe to moderate, and 10 went from moderate to mild. The handicapping effect on overall quality of life change does not necessarily mean that dysphagia improved. It's just how handicapping or how much of an impact their dysphagia has on their life and their quality of life. So 30% now viewed their dysphagia as having a severe impact. 50% viewed as their dysphagia having a moderate impact, and 20% viewed as having a mild impact. Conclusion. The results for Outcome 1 were measured and tracked by the DHI, which is a norm test to measure the handicapping effects of dysphagia and overall quality of life. The results from baseline compared to the results from post-treatment of cycle 3 show that even though these patients were near the end of life, their self-perceived quality of life improved, and this is seen by an overall decrease in the grand total score of each sub-area. Results for Outcome 2 were based off of initial evaluations conducted on patients' the fees. Recommendations given by the SLP were based on objective results, interviews of patients to find out what they thought worked the best, and observations of patients during treatment. Cycle 1 showed patients benefited from their diets but not from the swallowing maneuvers that were based on reduced strength. Cycle 2 showed that patients benefited from oral motor exercises, and Cycle 3 proved that patients would benefit from increased frequency in treatment. Thank you.